I'm Dr. Lakshmi. I am a pain specialist working out of Ashirvad Institute of Pain Management and Research in Dadar, Mumbai. I'm talking about a condition called complex regional pain syndrome, which has perplexed physicians for the last 1.5 centuries. I'm talking about the efficacy of ultrasound-guided dry needling, a very new intervention in reversing these terrible conditions. World over, there is no answer for this, but dry needling seems to provide the answer very well. In this presentation, I will show the scientific reason of just why dry needling is the correct answer for reversing not just CRPS but also the disability associated with it. It is meant for physicians who treat CRPS as well as the patients who suffer with it. Complex regional pain syndrome was first described 1.5 centuries ago, and after the American Civil War, the International Association for the Study of Pain called it complex regional pain syndrome. It is called CRPS2 when we can demonstrate a nerve injury, and CRPS1 when there is no demonstrable nerve injury but mainly soft tissue injuries are there. Moss et al. Did a study and published it in 2007 where they said 50,000 new cases are added in US alone. Incidence is 5.5 cases per 100,000 persons. Usually after fracture, 46% of cases are after fractures, surgery, trauma, and deep bruise or limb ischemia. Female to male ratio is 3.4 to 1. It is more common between the ages of 40 to 49.8 years. The most common inciting event is a fracture. Gottschalk et al. Reported 19 to 43% incidence after surgeries like arthroscopy, TKR, total knee replacement, and fractures. Go et al., this is a more recent paper, 2017, they said upper limb fractures can cause up to 32% incidence, and surgery upper limb can cause up to 11% depending on the type of surgery. Lower limb fractures account for about 30%, and lower limb fractures account for 30%, and lower limb surgery accounts for 31% incidence. CRPS may be mild and self-limiting. Unfortunately, this is uncommon. But most of the time, it becomes a chronic debilitating disease which impairs activities of daily life and health-related quality of life in a very big way. Children, fortunately, respond better to therapy and are less likely to have long-term symptoms, but they are also less likely to have a noxious event preceding the onset of CRPS. And unfortunately, they seem to have a 10 to 30% chance recurrence of CRPS, like this boy who's a 14-year-old with CRPS. CRPS manifests this way: sensory symptoms like severe pain, burning, hypersensitivity. She's just touching and he is unable to handle it. Some of them complain of insect crawling sensations, electrical shock-like sensations, etc. They also have a swollen, red, angry-looking hand, as this hand, and these are called vasomotor changes and pseudomotor changes. Later, trophic changes like increased hair and nail growth occurs. So 97% of patients have motor manifestations, decreased range of motion at most of the joints in the limb, difficulty in performing dexterous movements. So activities, self-care activities like dressing themselves, feeding themselves becomes very difficult for these patients. They also have stiffness and weakness. This lady, the moment she tries to use her hand, that's the way it goes. Another lady, she has to use her other hand to lift this hand. So these are myoclonus, dystonia, etc. And the disease has a very rapid progression. Here is this man who came first to me but postponed his treatment just by 1 week. And then within 1 week, you can see that he has worsened in the clawing of the hand has become much more. This is a 2017 review which says that there is no specific diagnostic test for CRPS. The pathophysiology of just why CRPS occurs is uncertain, and there are multiple proposed theories. One of them which is presently accepted is that it is an exaggerated inflammatory response to trauma, probably neurogenic inflammation. When they say neurogenic inflammation, they believe the primary pathology is in the nervous system, and that communicates itself along the nerves to the periphery of the hand or leg or wherever the CRPS is and causes an inflammation. That's why it's called neurogenic inflammation. There is no specific treatment. Only attempts are made at pain management with physiotherapy, psychological counseling, and sympathetic blocks. What sympathetic block is a procedure where an injection is done to some of the sympathetic relay stations in the body. Stellate ganglion is the relay station for the upper limb and face. Lumbar sympathetic ganglion is the relay station for lower limb. But the effectiveness of sympathetic blocks has been debated. A recent 2016 Cochrane review said that there is insufficient evidence to support or refute the use of sympathetic blockade. So the only treatment which is sort of there for CRPS has insufficient evidence. And the current outcomes in CRPS are uniformly bleak. A 2006 study reported impairment and disability in patients whom they assessed at 3 to 9 years. That means 3 to 9 years of a wasted life. Sharma et al. Published in 2009, failure of multiple interventions. Whatever is done to treat this condition is ineffective. 62% disability rate. The disability means unable to dress themselves, eat. These are basic needs which they are unable to fulfill. 96% sleep disturbance and 86% restricted mobility and self-care issues. DeMoss et al., their study is the one which is most valuable because this is a prospective study. They found 5.8 years later after the onset of CRPS, 64% of 102 patients still had CRPS. 31% were permanently incapable of work, and I think 28% had to make working adjustments. So, dry needling is the name given to an intervention that involves the insertion of solid 32 gauge needles into myofascial trigger points. We assume here that the pain in a muscle is coming from a myofascial trigger point. There is enough literature to support this. And when you insert a needle into the trigger point, it causes a reflex relaxation and pain relief by an effect called analgesic needle effect. This was first described by Carol Lewitt in 1979. As there is no injection, it is also known as dry needling. These are the needles. As you can see, they are very fine needles which range from 25 mm length to 120 mm length. But because these resemble acupuncture needles, it should not be mistaken for acupuncture. Dry needling has no connection with acupuncture. So also in US, Australia and rest of the world, there is dry needling is a term used by a process which is used by physiotherapists, physiatrists and occasionally neurologists, where they talk about inserting very short needles, 25 mm long needles, into specific muscles of the neck. This 2017 protocol for a randomized controlled trial of dry needling said only 6 sessions are done and 6 to 10 needles are inserted into the muscles. And they also do what is called as pistoning of the needle up and down to cause the needle effect, and also to elicit what is called a local twitch response. Now, the dry needling which I do, called ultrasound-guided dry needling, allows me to use very long needles, and the target here is the depth of the muscle. We know that there are myofascial trigger points all over the muscle and at its depth. And the use of ultrasound visualization avoids damage to pleura, nerves, viscera, etc. So we can go where we need to go to address the pain and the problems. So we use anything from 25 to 120 long needles. We use something like 30 to 50 needles. 6 to 8 needles have no meaning whatsoever in a condition like CRPS. And we use up to 12 to 20 sessions as against the 6 sessions described by the latest review on dry needling. So I mentioned the LTR. Local twitch reflex is something where when you introduce a needle, there is a jump in the muscle. Now ultrasound can demonstrate the jump. Needle coming in, there is a jump. I'll play this video again. There is a jump as the needle comes in. In CRPS, what happens is when the needle enters, there is not just one jump, but a crescendo of activity inside the muscle. This is because in CRPS, there is a tremendous amount of irritability in the nerves and the muscles. And also there are hundreds of MTRPs in these CRPS muscles. How I started dry needling in CRPS is because I had no answers for CRPS, like most of the world really. I used to do stellate ganglion block, and then I used to put in a very fine catheter into the brachial plexus, which supplies the whole of the upper extremity. And this is done very accurately in that we use a nerve stimulating catheter to place the catheter, and then the catheter is tunneled subcutaneously to go under the skin to a distal point to safeguard against infections. And then the tube is connected to an elastomeric pump, which gives a constant dose of 2 ml per hour, or it can also give a variable flow of local anesthetic. So what I am doing here is I am continuously causing anesthesia or analgesia to the nerves of the upper extremity so that the pain aspect of CRPS is taken care of. Obviously, my patients were very happy with the pain relief, but unfortunately, we weren't going any further than that. The other symptoms of CRPS kept recurring. So motor recovery was very uncertain. It would take something like very slow, 2 to 3 months it would take. This is a patient after 2 months of continuous block where he is unable to use his hand still. Keeping a catheter is not a simple thing. There are attendant problems like catheter extrusion where the catheter walks off by itself, or infection, etc. In 2006, a patient of shoulder hand syndrome, which is a type of CRPS, came to me. She had severe sensory disturbances, sleep disturbances. This is called allodynia, where a simple touch is considered as being very painful. She also had other symptoms like pseudomotor changes of swelling and motor changes of very slow movements and restricted range of movement at the shoulder and hand. As you can see, the normal hand can go there, but she is unable to go even beyond this. So in this lady, I did a stellate ganglion block as I normally do, and a continuous brachial plexus block, stellate ganglion as visualized on X-ray with a dye study, and a stimulating catheter being inserted into the brachial plexus. But 7 days after my sophisticated block and catheter, the lady still had pain, significant painful restriction of range of motion at the shoulder. When I asked her, she pointed out to her pectoralis minor, coracobrachialis and other muscles as being the painful regions. So I said I was already familiar with dry needling at this time for other myofascial pain conditions. So I said, let me try doing dry needling in this patient. So I inserted few needles into the muscles which she pointed out as being painful. This is the biceps, this is the coracobrachialis, and this is the pectoralis minor. And immediately after dry needling, a lady who could not go beyond 80 degrees, she's right there. So I didn't understand what was happening, but I was happy. And in this lady, she showed complete recovery within 18 days. My other patients used to take 2 to 3 months and would not get complete recovery. And the interesting thing in this patient is we used no opioids at all. I never use opioids anyway in CRPS. So she has received complete mobility within just 18 days of needling. So I thought it was a fluke, some kind of a fluke, I didn't understand. But then I found that all the other patients also continued to be uniformly consistent and improvement with dry needling. This is the boy who has severe pain on touch. And after 3 sessions of dry needling, you can see that his hypersensitivity is gone. And not only that, he recovered completely from CRPS, and he continues to be normal 4 years, 5 years hence. I have reported this in Pain Medicine Journal. So, in addition to the pain, the pseudomotor and the vasomotor changes also would disappear. This is the patient within 3 weeks, and this is another patient within 3 weeks. A man who could not lift his hand also is able to write in 3 weeks. What I found was, if the pre-dry needling temperature was 37 degrees in the hand, when the needles were in situ, it was still 37 degrees. But after the needling, it would go down to 34, indicating a reduction in inflammation. So there was a direct correlation between the temperature change and dry needling. So this is showing a patient with needles in the flexor aspect of his arm, and the muscles were needled were these. And we also do alternately the extensor aspect. Now, with our 14 years of experience of ultrasound-guided dry needling for CRPS, we have found that it causes not just pain relief, but complete reversal of CRPS and its disability. We have done this in about 173 patients, consecutive patients I may add, and who returned to prior lifestyle and profession. This means that whoever got treated by us had a complete reversal. So upper extremity was 130 patients of CRPS 1 and 6 patients of CRPS 2. Lower extremity, 26 patients were reversed and 4 patients of CRPS 2 were reversed. We used no opioids at all in CRPS. We use EMLA cream, which is a local anesthetic cream, to allow the needling. We use NSAIDs or painkillers before the dry needling to facilitate it. I may use stellate ganglion block and continuous brachial plexus block if the patient finds it difficult to go through with the needling. So it's a choice which is offered to the patient, and the patient chooses what they want. So we have published our results in various journals like Pain Medicine, Pain Practice, and Pain Physician Journal. Our usual course of events in a CRPS patient is, on day 3 they come like this with a clawing of the hand, and later by day 10 they are like this, they are able to flex their hands, and by day 17 here is a lady who is able to grasp the bulb of a dynamometer, but she is unable to generate more than 0 psi pressure, whereas her normal hand is generating about 8 pounds per square inch pressure. By day 22, the same lady, this hand, is able to generate about 4 pounds per square inch. So when a patient presents with severe dystonia like this on day 1, we do dry needling. After 20 days, this is the way they are. These results are very consistent, predictable, and we always find them. So I was very happy with the results, but my biggest problem was, why is dry needling giving me this kind of results? I had no clue why it was giving me these results. I kept puzzling about it. But 1 year later, when I was observing this patient, I got my answers. You can see how difficult it is for him to flex. Just why this is happening occurred to me, and this is what I find, that when the flexors of the hand contract, when the flexors are contracting, the extensors should relax. And when the extensors are contracting, the flexors should relax. There has to be reciprocal action between the agonist and antagonist muscles to produce a streamlined, coherent movement. In CRPS, instead of this coherent movement, flexors and extensors contract simultaneously, and this is called as co-contraction. And co-activation has been described in CRPS in one paper. And what happens is, the mechanism of why the swollen red hand happens is, the muscles are here, but the tendons are here. The tendinous insertions, the patient pulls when she does these movements. That causes a local inflammation, and that's why they get the... So this is the local inflammation which occurs here. The problem is in the muscles of the forearm, but it manifests in the hand, because in the hand there is what is called as a synovial membrane which lines the tendons. Synovial membrane is a very sensitive structure with a very huge nerve supply, and as a result, when it is inflamed, there is a lot of swelling, lot of pain, lot of redness, lot of all kinds of distress. So this is an animation that shows the genesis of this tenosynovitis. Please note that he is unable to move. He is trying to contract, but nothing much is happening. The muscles here are very tight and he is unable to do anything. But later, as he tries to move more and more, the tenosynovitis, which happens in the hand and fingers, causes this tremendous inflammation which manifests as CRPS. Here is a situation where ultrasound can distinguish between the tenosynovitis. See, these are the tendons of the hand, and the black shadow around it is the fluid inside the tendons, inside the synovial sheaths. Whereas if you see simple swelling, not CRPS, but just a simple swelling of the hand, you will see that the tendons are free, there is no effusion around it, but the fluid is all in the subcutaneous tissue like this. This patient with the swelling around the tendons, after treatment with dry needling, the edema around the tendons has disappeared and the tendon is free here. Clinically, this patient presented like this with the swollen hand, and after 3 weeks you can see the swelling is gone and she is flexing the hand. So complex regional pain syndrome does not occur after a fracture while the patient is in the splint, but occurs only after mobilization starts. When the patient tries to move the tendons and the fingers, that is when the inflammation, friction, inflammation, and the manifestations of CRPS comes up. And this is a patient who's showing swelling around the tendon here after just 7 days of mobilization. Because of the tenosynovitis symptoms are very severe, very, very severely painful, and they subside if the hand is rested. So the waxing and waning of CRPS symptoms happens when the patient does some work, the swelling comes, and then when he stops working, the symptoms go away. So this causes the patient to avoid using the hand altogether, and this is called as neglect-like syndrome, which is characteristic of CRPS. The neglect in this patient is so severe that he is completely unable to move the leg, and there is pus oozing in his web spaces because he is not going to clean it or touch that leg even. And this patient was treated with opioids, nerve blocks, etc., but it didn't work for him. So when I saw him, I started a continuous sciatic block. Sciatic nerve is what supplies the foot. And I treated him with dry needling also. And the same patient who could not even move in bed He is walking after 2 months. Another patient, a young girl of 26 years who had severe rheumatoid arthritis. She had hip replacement, and after hip replacement she developed CRPS. I saw her 1 month later when she was like this. The normal hand, this is the normal foot. The temperature is normal. The CRPS foot is hot, angry, and there is also peeling of the skin here. This lady, after treating her with sciatic block and needling, after 3 weeks, she is walking normally. So, also note the interest back of nail paint and other things. So, now I knew there is something wrong with the muscles in CRPS, but I had no objective proof till I saw this girl who came to me after a fracture of the metacarpal bones of the hand, 18 months after the fracture. She was completely unable to use the hand. This is the maximum she can flex this hand. I looked at her muscles on ultrasound. This is what the normal muscles look like. Nice, clean outline, a predominantly black background of muscle cells which give an uniform echo with white streaks, curvilinear, hyper-echoic white streaks in between the black background. This is the normal appearance. This is her normal hand, but her CRPS hand looked like this. There is a profusion of fibrous tissue and no trace of muscles. There is absolutely no organization of muscle outlines or anything like this. The muscle bulk also is drastically reduced. The hand looks wasted. So the same girl, when I treated her with dry needling, I could see the reappearance of muscle outlines coming in. So this was the objective proof that I was looking for. Along with this objective evidence of muscle improvement, the clinical improvement also occurred, and the hand which she was not able to flex at all, she is now making a fist. So CRPS muscle structure disruptions are consistently seen in all our patients where I have checked that. And in the early stage, it may not be very obvious, but it involves only the digital flexors and extensors. Whereas in patients with severe CRPS, more than 3 months, the whole muscle structure is completely disrupted, and this is what it looks like no muscle at all. It looks all fibrotic. So I have published these results in Pain Practice in 2013. I have suggested that ultrasound can be a diagnostic modality in CRPS. Unfortunately, not many people are familiar with ultrasound as a diagnostic modality. Most of the pain physicians may use ultrasound for doing performing blocks, but the diagnostic aspect they are unfamiliar with. Radiologists who are familiar with the diagnostic capabilities of ultrasound, they don't see CRPS at all. So there has been a problem in reproducing my results, but I'm seeing this consistently in all our patients. So at this time, when I suggested that ultrasound can be a diagnostic modality in CRPS, only bone scan was one of the diagnostic modalities. In late stages of CRPS, you see this, or X-ray changes like diffuse osteopenia, juxtacortical demineralization, etc. There is also a difference in the muscle structures when you see a normal neuropathic pain patient. The patient has neuropathic pain, fairly severe pain, but it does not follow the galloping course of a CRPS. In those patients, the muscle structure is retained, whereas in CRPS, within 3-4 weeks or even a month, this whole structure is completely lost. So we have presented one study, published one study, where we did clinical as well as ultrasound correlation in about 50 patients. This patient started with inability to grasp the dynamometer, zero PSI, and after 1 month, he is able to generate something like 11 pounds per square inch. The goniometer is an instrument that measures the angle at the fingers, at the joints of the finger. This was very poor when we started, but from 35 degrees it has progressed to 90 degrees flexion within a month. And the finger also went from 0 psi to something like 7 psi pressure. The ultrasound which showed a disruption like this showed a reversion to normal in these patients. So 50 patients' data has been published already. So how to correlate the present prevailing thoughts on CRPS and what I am seeing in my practice? The CRPS is considered to be a neurogenic inflammation. Having assumed neurogenic inflammation, what do we do about it? There is no treatment for it. How do you stop the neurogenic inflammation? So the theory of neurogenic inflammation offers us no clue as to how to proceed with the treatment. The data in myofascial trigger point literature, Simmons proposed that there is an energy crisis in muscles which causes the myofascial trigger points in muscle. It is called the integrated hypothesis. So I propose that co-contraction that we see in CRPS leads to severe muscle ischemia resulting in structural disruption, which is the primary problem of CRPS. Its consequent tenosynovitis is what causes the clinical symptoms of CRPS. So to explain in theory, this is the nerve end, this is the muscle, this is the neuromuscular junction. These indicate the acetylcholine molecules which initiate the muscle contraction. When there is irritation in the nerve, there is an increased release of acetylcholine. The acetylcholine receptors in response increase in number, and there is a reduction of acetylcholinesterase which dissolves the acetylcholine. Because of this increase, the normal electrical activity of the muscle is like this, where these are called miniature end plate potentials, which is simply a flicker which happens now and then. Whereas because of the electrical activity increase at the neuromuscular junction, in myofascial trigger points, there is a complete noise here which is going on, which Simmons has called as end plate noise. And this leads to local sarcomere contracture. This is what a sarcomere looks like. Sarcomere is the smallest unit of the muscle. When you look at it, this is the myosin, this is the actin, and there is what is called as a Z line and an I band. This is the relaxed muscle. But when it contracts, the I band disappears and the Z lines come closer to each other. That's what causes the muscle contraction. And when this happens, when there is a contracture, that is a sustained contraction of the muscle which just does not relent, it can cause ischemia, acidosis, and local energy crisis. We are talking of a contracture which just does not relent. That is why it causes a local energy crisis. This leads to inflammatory mediators inside the muscle that can cause peripheral sensitization of the musculosensory nerves. That means there are sensory nerves inside the muscle which carry this sensation of inflammation, and they get sensitized because of constant stimulation. This causes the musculosensory nerve sensitization, causes nociception or pain. This leads to autonomic stimulation. That is, whenever there is pain in the body for any period of time, or if the pain is very intense, it causes a stimulation of the sympathetic nervous system. This is called as sympathetic recruitment. So when in CRPS, when we give a stellate ganglion block, we are treating the autonomic response to ongoing pain. And the continuous brachial plexus block that I used to use in my patients hits it at the pain, in the sense that I am avoiding the pain in the hand in CRPS. Neither of these treatments affect the sarcomere contracture that has happened because of the constant stimulation at the nerve ending. So the primary motor pathology is not addressed either by stellate ganglion block or by the continuous brachial plexus block. It is only dry needling which can hit this primary pathology of CRPS, or for that matter any myofascial pain condition. CRPS is just, you can consider it as the worst galloping kind of myofascial pain syndrome. Sorry. So this is what a CRPS muscle looks like. I have done nothing to this muscle. I am just observing the muscle which is in CRPS. There is co-contraction which is going on, and that is leading to lot of activity inside this muscle. This is an unrelenting, constant co-contraction of flexors and extensors. This leads to severe resource depletion followed by ischemic damage to the muscle fibers. It also causes the pain. So if I were to correlate the integrated hypothesis to complex regional pain syndrome, the muscle fibers seem to virtually disappear from within the endomysium and perimysium, that is the connective tissue framework, because of ischemic damage from constant co-contraction. If you consider this as the basic unit of the muscle, or the muscle cell, or a muscle fiber, many muscle fibers are enclosed within a fibrous tissue framework to form what is called as a fascicle. And many fascicles are put together inside a muscle. What happens is, what you see as red here is the muscle fiber. What you see as white is the connective tissue framework. In an ultrasound, the red is seen as black and white is seen as white. And aggregation, when there is disappearance of muscle fibers here, the aggregation of the fibrous connective tissue framework gives the ultrasound appearance of extreme hyperechogenicity. Loss of contractile hypoechoic muscle fibers, that is the black muscle fibers, causes the weakness in these patients, while the predominance of persisting tough connective tissue leads to a worsening of the severe stiffness which is already present because of the co-contraction. So this is an animation which shows how the muscle virtually disappears. Muscle, because of the resource crunch, the muscle is disappearing, and we are left with a skeleton, fibrous skeleton of a muscle like this. So when we do dry needling in CRPS, this elicits a crescendo of local twitch reflexes all over the place. This is a muscle which is already trembling before we put the needles. That becomes even more when we put the needles into these muscles. However, what happens after 10 minutes is very interesting. When you observe the same muscle after 10 minutes, you can see that the muscle has quietened. The activity is not much there. Here and there are a few flickers. After 30 minutes, you can see that again the quietude continues. This is what a normal muscle looks like. And there are flickers, occasional flickers. So dry needling directly reduces the severe co-contractile activity in these muscles. This same patient, when seen 4 days later, there is hardly any activity inside the muscle. This is before dry needling. So the patient reported that there is a significant reduction in pain, swelling and warmth. Just one session is enough to produce a very major change in these patients. So let me come to what the muscle looks like in histopathology. When you cut a muscle and take a section and see what happens in CRPS. In the olden days, patients were used to be so harassed by these pains that they would opt for an amputation. Here is a hand which does not give any work, so they said, please cut it off. Then they were amputated. The hand was amputated. This did not stop their pain. This added another dimension to their pain of phantom pain. But the muscles which were from the amputated limbs showed certain changes in the muscles. This has been reported, Hulsman and Vanderlaan et al. These muscles showed atrophy, fatty degeneration, and nuclear clumping. I thought, let me see if I can show these results in CRPS patients. Here was a patient who came to me after knee replacement. He developed CRPS. This is seen very well as the orange, angry right leg with normal left leg looking like this. He was just 2 months into CRPS, very early CRPS. But when I took a biopsy from one of his muscles in the knee, around the knee, rectus femoris muscle, you can see that the report says this is an atrophic fiber with clump nuclei. Fortunately, because he had come to me early, few of the fibers showed this change. However, another patient who came to me after 2 years, this is what it looked like. Blue means fibrous collagen tissue and red is muscle tissue. You can see that there is a extreme predominance of fibrous tissue in these muscles. So here is histopathological evidence of what I am saying, that there is muscle loss in CRPS because of constant hyperactivity of co-contraction. So based on the understanding of co-contraction, CRPS presentation can be very varied, which is what leads to the confusion which prevails in the present day literature on CRPS. Because CRPS varies, sometimes it's absent, sometimes it is seen, but what causes these varied presentations is it's an interplay of co-contraction, how much co-contraction the patient develops, how much inflammation this co-contraction produces by tenosynovitis, and how much resource crunch happens because of co-contraction in every patient. These differs from patients to patients. Inflammation comes from tenosynovitis, ischemia comes from the constant co-contraction, and stiffness comes from co-contraction plus fibrosis. Peripheral sensitization, that is the pain, comes because of repeated inflammatory insults to the hand. Then because of constant pain, there is central sensitization where the nerves right up to the spinal cord and brain are sensitized or irritable. Behind all this is the patient's attitude to pain, ability to work with a physical therapist, tendency to catastrophize. That is, when there is little pain, the patient will say, oh my God, this is going to become worse, this is going to become worse. That's called catastrophization. Versus objectivity in the patient. If you have a patient who's very objective, who's got some amount of the right attitude in that little pain is okay, I will work with it, this patient will work with the physical therapist very well and probably revert. This explains the milder cases of CRPS. But patients where the co-contraction is severe, the inflammation is severe, and the pain from tenosynovitis overcomes or overpowers their tolerance of pain, they cannot work and they gallop to the conclusion of a long-standing debilitating CRPS. So when the joints get, so far I have spoken about the muscles and probably the nerves, but when the joint synovium gets involved, the hand is full of joints. So when the synovium is involved, that adds a whole new aspect of worsening to the pain of CRPS and its presentations. This is published in an article. So as I would like to reiterate, current outcomes in CRPS are uniformly bleak, but they need not be bleak. With a paradigm shift in understanding of CRPS pathophysiology, reversal of CRPS could be routine as it is seen in my clinic. But to make this routine, we need further scientific assessment of ultrasound-guided dry needling by other people and other centers than my center. And we also have to perform randomized control trial studies. To do this, the other physicians have to be ready to learn ultrasound-guided dry needling, which requires a thorough regrounding in anatomy. And most important, inclusion of ultrasound-guided dry needling as an intervention covered by insurance, because we can't keep on treating patients free. It is too energy consuming, time consuming, and resource consuming to treat them free. So, to conclude, our work demonstrates that muscle involvements in pain and disability in myriad pain conditions believed to be neuropathic or arthritic can be because of muscle problems. Ultrasound guided dry needling alone or in combination with other modalities like stellate ganglion block and continuous brachial plexus block can alleviate both pain and disability while allowing the patients to reduce or discontinue opioids. This becomes very important in the context of opioid crisis presently prevailing in US and the Western world. Thank you very much.